Okay. So as Jill mentioned, my name is Bautista. I'm in a little bit of a limbo phase that I've defended, but my degree is to be conferred in May. I'm also currently working as a research associate at the Center for Mindfulness, Compassion, and Resilience at Arizona State University. And I will say a little bit about our program at ASU. So the PhD is Nursing and Health Innovation in the College of Nursing and Health Innovation. And it is a transdisciplinary degree, so we have scholars from all different programs, all different backgrounds, from public health, nursing, a few physician assistants, architect, psychology, pretty broad range. And we all go through the basic core programs similar to other nursing PhD programs. So we have nursing theory, nursing philosophy, nursing policy, and then from there we can do an a la carte build your degree specific to your needs and what your discipline is. So I took a lot of my stats classes in psychology, some of David McKinnon, if anyone knows mediation analysis, that was great. And then I also took some classes in social work related to substance use disorder and treatment and care there. So I was able to mix and match and see what was best to get me to my ultimate career goal of having the independent research lab. So today I'm just going to present a very small piece of a broader area of research. So I'm going to be talking about the acceptability of a mindfulness-based intervention for substance use disorder specifically. So I do want to introduce you a little bit to what substance use disorder are. Some of you may work in substance use disorder. Anyone? Okay. Anyone work in interventions broadly? Okay. And I think health disparities is probably our most common overlap. So everyone will be familiar when I get to that area. But substance use disorder specifically affects over 20 million Americans and usually costs us over $400 billion annually. Even when we are able to get individuals into treatment and have a complete treatment, there's still a very high relapse rate. So treatment and relapse prevention is a high priority within the NIH funding area. So one of the interventions that we have to treat substance use disorder is mindfulness-based interventions. And this is part of the third wave of empirically tested cognitive behavioral therapies. And they've been developed for a wide range of issues wherever stress is a common underlying threat to the illness. Mindfulness-based interventions have been adapted to treat that. So stress being a common trigger for relapse and for use, mindfulness-based interventions are effective there. So all mindfulness-based interventions have some things in common. We have a lot of different adaptations and things that get added or taken out, but the core practices within my mindfulness meditative practices are here. So when I'm grounded in silence, stillness, self-inquiry, embodiment, emotional sensitivity, and acceptance to emotional expression. I actually kind of want to take a minute and pause here, and we're going to do the mindful practice with your food in front of you. So this is a mindful eating practice. Has anyone ever done a mindful eating practice? Okay, so you'll be a little ahead. If you haven't, just open yourself to allow to experience it. This is, of course, voluntary. If you don't want to, you can just sit in silence and breathe. But so let's start with just putting our feet on the ground and sit in a way that brings awareness to our posture. You got to be comfortable, not rigid, but just aware of your body. And we're just going to check in with our breath. So follow each breath. If you're comfortable, you can close your eyes. If you don't want to close your eyes, just keep a soft downward gaze. Take a few minutes to just breathe. It may have been a busy morning. We're now transitioning from morning to afternoon. Give yourself a minute to just sit here. Catch your mind if it wanders away, knowing that the only thing on your to-do list right now is to breathe. Everything else will be there. Now, keeping this awareness of your mind wandering, staying in the present moment, you can reach out and grab one of the items in front of you. Doesn't matter which one. And open your eyes softly. For this practice, we want to stay internally focused on us, not allowing ourselves to be distracted by others in the room. Just look at the item in front of you. You may feel it. Notice the texture. Notice the colors. Maintaining sense of your breath. You may have a memory related to this item that comes. You can watch that memory flow by like a cloud, staying in the present moment. And bring this item to your nose to smell it. Notice any feelings or emotions related to it. And place the item in your mouth. Notice the taste. Still maintaining present moment awareness, touching your mind as it wanders. Go ahead and finish the item. Notice any lingering taste. How long does the taste last? And now taking in another deep breath. And fully exhaling. Allowing your body to rest. The next exhale, bring a little movement to your fingers and toes. Your eyes are closed, blink them. Stretch a little. Start to notice people around you. Come back into the room. Had a bell every minute. So this is a mindful eating exercise. And the goal of this is similar to what these are here. We want to ground ourselves in silence, noticing any sounds in the room, any sounds of the item in your hand, not allowing it to take us away from the present moment, still staying here, but completely noticing as much as we can around us. Noticing when our mind wanders to your emails, to your grading, to your shopping list, and then bringing it back. That these are just a few moments that you have to just sit and breathe without any other tasks. So these, as I mentioned, have been developed for a wide range of different illnesses and conditions, but also just for general well-being. So I do mindful writing groups 3 times a week with other early career scholars, where we just meditate and then we write. Because how often are we writing and our mind takes us off and then we start Googling something and then we have to work in this data real quick and then we run away. I haven't gotten anything done. So meditation really helps with that. So meditating a few minutes before you start working on a project as well. So as I mentioned, today we're going to be looking at mindfulness-based interventions specific to substance use disorder, but I wanted you to experience a mindfulness practice so you understand what I'm talking about when I say mindfulness. So there's some reasons why we think mindfulness-based interventions would be effective for substance use disorder. When we look at the target in the mindfulness-based interventions, the things that we work on, which you may have noticed just in that short practice that we did, there are associated brain areas with these practices that are activated, and these areas are also associated with different neurocircuitry and addiction. So these are hypothesized mechanisms as to why mindfulness-based interventions would be effective for substance use disorder. Oops. One of the problems where my research comes in is that mindfulness-based interventions in the US are historically reserved for educated, white, upper middle class individuals. They're typically very expensive and often not tested within minority population. So we don't want to take a program designed for one population and just pick it up and put it to the population and say, if it doesn't work, it must do the people, right? Everyone working in health disparities understands the issue with trying to take a program from one group and just throw it into another group. So we need to adapt it. And one of the reasons we need to adapt it is because we need it to be acceptable to the new group. So when I talk about acceptability, I'm discussing a multifaceted construct that reflects appropriateness based on anticipated or experienced cognitive and emotional responses to the intervention. So there's some significance as why we would want to measure acceptability. We understand that when an intervention is perceived to be acceptable by the participants, they're more likely to adhere to the teaching and then in turn benefit from the teaching. And if facilitators perceive the intervention to be acceptable, they're less likely to adapt or alter the intervention in an in vivo moment that may not be congruent with the fidelity of the intervention. We understand that there's a growing priority in measuring acceptability in studies. Just within the last 15 years, we went from not talking about it at all to it mentioned 14 times within the Medical Research Council. Even with it mentioned 14 times, they didn't give us a conceptual or an operational definition, just tells us we should be measuring it. So this brings in a whole other issue of measurement. Within a paper by Sedholm, he reviewed 43 systematic reviews of healthcare interventions, and none of them mentioned a theoretical framework for acceptability. So that led me to my own systematic review, where I reviewed 17 mindfulness-based interventions. Of the 17, only 4 mentioned the word acceptability at all. Of those 4, the way that they measured it was satisfaction, practice, follow-up or retention rates, or attendance to the intervention sessions. They always measured acceptability at the end of the intervention with intervention completers. And they all concluded the intervention was acceptable, which is a good thing, we think, if it's properly assessed. We don't want to assume that it's acceptable if we're not accurately assessing the concept. But none of them assessed any type of variation in acceptability. So there were also 6 studies of the 13 that didn't mention acceptability at all. There were 6 of them that used the items that I mentioned earlier, but they used them to assess feasibility, not acceptability. So these are the exact same terms that were used in other papers to conclude acceptability, now being used in other papers to conclude feasibility, which also creates confusion within the field of what should I use when I want to test acceptability and what should I use when I want to test feasibility. There are some issues with using retention, completion, attendance as a measure of acceptability, especially when we're looking at inpatient rehabilitation centers. Someone can complete an intervention without accepting it, especially at residential treatment facilities. Very easy to go to class every day, follow the assignments, and never actually adopt any of the practices. Individuals can also accept the intervention without being able to complete the intervention. So they may be transferred to a different facility. They may have court hearings where they miss class. They may have time with their children, or a lot of things that are pulling them out of the session, although they are actually practicing, adopting the interventions, and really enjoying themselves. So it's not the most accurate way of measuring it. So that's why I have some of issues that I found when I did my systematic review, which led me in my study to using satisfaction as practice as more accurate measures of acceptability. And also noticing that there's a lack of initial acceptability, and we have a lot of research in first impressions that really say it's important for them to adopt it early in order to sustain and continue on. So I wanted to assess initial acceptability of an intervention using practice and satisfaction. So a few other things that came up from reviewing the literature. There was a lack of attention overall with assessment of acceptability. Many will say we concluded acceptability because there was a 70% completion rate. Others will say there was high satisfaction without actually mentioning their satisfaction tool in their method section. So we don't actually have accuracy or understanding of how they are concluding this. Also a lot of inconsistent types, as I mentioned earlier. And the, one more thing that came up was that most of the definitions of acceptability say that it's multifaceted, yet most studies use one measure to conclude acceptability. So what I propose here is that if we're using a single construct, that we just conclude from that single construct. If we're using a satisfaction survey, let's conclude that the intervention was satisfactory. Let's not conclude that it's acceptable if we're only using satisfaction as a single construct. So this led to my current study where I was working with a mindfulness-based intervention for substance use disorder called Moment in Moment Women's Recovery. And this was specifically adapted from the mindfulness-based stress reduction, which is the kind of parent intervention. But it was specifically adapted for ethno-racially diverse women, low literacy, low income, added relatable content and examples, and it had a clinician in all the sessions to help with trauma and mental health issues that could arise.
So it was 80 minutes per session. Sessions were twice a week for 12 sessions over 6 weeks. This was an inpatient in residential treatment center, and all of the MMWR facilitators were trained in both MBSR and MMWR. And as I mentioned, there was an on-site clinician. All of the lesson plans are standardized with a manual. So the class segments were divided into 5 parts. Each class would start with a welcome, go into a presentation, then a practice that was related to the topic, and then one of the core practices, and then they would conclude with reviewing or reading and practice the assignments that they would do over the next week. So all of the women received an MP3 player where they could practice the different meditations on their own between classes. These are some of the topics that each went through, specifically related to mindfulness and the specific population we were working with. So I won't read all of them, but I'll let you kind of read through. So the purpose of the current set is I'll present for you today. The first was to test the intervention and personal characteristics that could be associated with acceptability. The 3 specifics that I picked out were time and treatment prior to starting the intervention, assuming that individuals that had been in treatment longer may be more adjusted and ready to adopt a new practice. The second one was mindfulness predisposition. We hear a lot that some people are mindful and some people aren't, and that's just how they are, and some people will not accept this intervention. So I wanted to see if that really was a factor. And then the third was trauma severity, and that we hear a lot of people that we need trauma-informed care. So we've created a trauma-informed mindfulness-based intervention. Is trauma still a factor that's going to influence acceptability? And then finally, we wanted to test if acceptability had a predictive association with mindfulness application at the end of the session. So these traits that I mentioned here were all measured at the baseline. Practice was measured at session 3, satisfaction was measured at session 2, and we want to see how those influence at the end of the last session, how much application of the techniques are they using. So all of the screening assessments were conducted to determine eligibility, and then we were reached out to the participants for them to consent if they were interested, and had in-person interviews for additional assessments. Additional information was taken from their clinical records, and then, as I mentioned, acceptability data were administered in surveys during intervention sessions. These are the inclusion-exclusion criteria, which are pretty typical when working with clinical populations that would fit within the study. Covariates that I used for this model were age, education, and race ethnicity. Time in treatment was assessed using the number of days from the day that they entered treatment to the day that they started the first session of the intervention. Mindfulness predisposition, as I mentioned earlier, this is how mindful they may be without any type of mindfulness training, and that was measured by the 5-facet mindfulness questionnaire. Trauma baseline was using the post-traumatic stress scale self-report. Won't spend too much time going into these, because I want to get to the fun stuff. Satisfaction was measured at session 2 with 17 items, and a sample item, how much did you enjoy participating? And then formal practice and informal practice both measured at session 3. For formal practice is how often did you practice a walking meditation, which is a formal type of practice that you would set aside time for to work on. While informal practice is how often did you notice to use mindfulness to be aware of your emotions. So it's not necessarily something you would set aside time formally to do, but it's something that you're using mindfulness during your day to work with. So then applied mindfulness is more looking at specific application when something happens. So to see that my thoughts are not necessarily true, I'm applying it to my daily life. So these are the participants that we're working with. There's 100 women in the intervention group. We also had 100 women in an active control group, which I don't really have time to go into today, so I'll focus on the intervention group. But if I have another session another time, I'll share with you our results there. So our age was around 32. The majority of our participants identified as Latina Hispanic. We had a little less than a 12th grade education on average. The majority identified as living at somebody else's house or homeless 8 months prior to treatment. The majority were also mandated to treatment, and the majority also identified as Christian. So if we get into the correlation, these are just the variables that I mentioned earlier. And then we also have our means over here. So if we want to just look at a mean, which is a lot of times how satisfaction is reported, just reporting a mean, we would see that we have a high satisfaction. And then our practice is, so this is about at a 2, which would mean that they're practicing 2 or more times per day on average. And this is a little over a 2 for informal practice. And then we also do see, I'll say here, a high correlation between our formal and informal practice. We only have one model where they're used together, and I did check for variance inflation factor, and we didn't have an issue with multiplicity. That was good. It's also nice that it's a large, but it's not like a 0.8 or 0.9 where we would say it's the same construct. There is some individuality between the 2 constructs, which is nice. We didn't see any super strong correlation over here with any of the variables that we thought we would. We do see that age is correlated with formal practice and education is correlated with informal practice. So we use those as covariates in the respective models. So let's get into, we also tested for race ethnic difference, and we didn't see any significant difference between race ethnicity on any of the 4 outcome variables. We do see this approaching significance, so I did do post hoc analyses, and with any of the corrections, it's not even nearing 0.05. So we didn't worry too much about differences in satisfaction. So for our outcome variable of satisfaction, we didn't see any significant predictors for satisfaction, which we thought we would have seen, but also can give us some good information, and that when engagement treatment doesn't predict satisfaction, meaning that it's not those that have been in longer enjoy it more, it's kind of even across. Those that have been in only a few days, they also enjoy it as much as those that have been in for a month. And then same with mindfulness predisposition, no effect there. So mindfulness predisposition, those that are more mindful naturally didn't necessarily enjoy the intervention any more than those that were less. And then the same with trauma severity. So when we look at formal practice as the outcome variable, our strongest predictors were age, positively. So the older they were, the more formal practice they were participating in, and trauma severity positively. So the higher trauma severity they had, the more formal practice they were participating in by session 3. We see a similar pattern with informal practice with mindfulness predisposition and trauma severity. So the more mindfulness predisposition they have at baseline, also the higher trauma severity, the more informal practice at session 3. And then finally, a mindfulness application at the end of the intervention, our strongest predictor was satisfaction, which was exciting, and also now we need to know what predicts satisfaction because we didn't have any significant predictors of satisfaction in that regression model, but now we know that that actually is the strongest predictor for applying mindfulness at the end of the intervention. So as I mentioned, time and treatment didn't predict any of the variables, so that may indicate that we may be able to introduce it sooner. There have been a lot of concerns with introducing mindfulness interventions too soon, but there are also some interventions that are introducing it even during detox. So ours was minimally after detox, but there may be something to allowing participants to enter sooner, in that it wouldn't affect acceptability. There are a lot of other factors to consider what it may influence, but as far as acceptability is concerned, it may not be, it may not be too worrisome. Mindfulness predisposition, as I mentioned, was related to informal practice, but not formal practice for satisfaction. So really what we're saying is that they may not have as frequent an informal practice by session 3, but otherwise not a huge contributing factor. And then as I mentioned, so we really want to see what is predicting satisfaction if we know that that is the strongest predictor of mindfulness application. We were glad to see there were no race ethnic differences because the intervention was designed for ethno-racially diverse women. It's good that there aren't large differences, but we do mention that 60% of the sample belongs to one racial ethnic group, and that could be influencing it slightly. And trauma severity was a positive predictor, and much of the literature says that it would be a negative predictor, and that more trauma severity, less able to practice mindfulness. So this may actually be a coping mechanism that they're enjoying more than other coping mechanisms. And when a re-experiencing or other trauma trait may be coming up, they're using this as a practice. So some limitations, of course, to the study, as I mentioned previously, and have been going through. This is a smaller sample size. We have 100 women. While we're powered for the regression models, it would be great if we could also test third variable mediator moderator effects. I think there is something going on between trauma severity and mindfulness predisposition at baseline that I want to explore a little more. And we also, of course, want to assess acceptability longitudinally. So as I mentioned, this is initial acceptability, but we also have assessments for practice at 6, 9, and 12, and satisfaction at session 11. So we can look at how it changes over time. So some of the implications for this area of research, as I mentioned earlier, interventions are not one size fits all. We can't take the same intervention and put it in any group, but we also can't personalize every intervention if we want to be able to scale up and deliver interventions to wider groups. So if we can identify specific participant characteristics, we can tailor an intervention without specifically personalizing it to each individual person. Which leads me to some of my other work in intervention adaptation, which one of the issues that we've brought up is that there's a problem with just adjusting surface structure rather than deep structure when we're adapting interventions. So when we talk about surface structure, which is also important, but it can be kind of superficial. So it's changing the language of the intervention and then putting it into a new group. Now that's the same language, it matches and it's fine. So that's a starting point. But if we really want to adapt interventions to fit and be acceptable, we have to go deeper into deep structure intervention adaptation, which is adding the relatable content and examples going beyond just a superficial language group that could affect it. We need to take into account cultural, social, historical, environmental, and psychological factors. So social determinants of health, I won't go into this too much because I know this group knows it pretty well inside and out. But these are some of the areas that we need to take into consideration when we're adapting an intervention. What are their challenges or determinants that could be affecting their ability to adopt an intervention or a practice or even attend an intervention or get any type of health care. Health disparities, which I mentioned, kind of our overlap between all the groups. So again, we'll go into too deep into it because I know everyone knows it pretty well. This is just something we need to take into account when we're looking at adapting an intervention. What are the health disparities that we're looking at? Do they have multiple health disparities that are working against the group that we're trying to help? And how do we create an evidence-based intervention that can reduce the health disparity? So if we want to reduce health disparities, we need to eliminate the health inequities. We know that, right? So how do we create intervention that is effective in the community while having a higher level of broader dissemination to a greater group? So that's where we're going from here. This is where we're at. That's where we want to go. We want to get to a point where we can scale up interventions for broader dissemination that are applicable to larger groups while relatable and relevant to specific groups that are also cost effective. If we want government to help us, to fund us, we have to say why it's better to put them through this program than it is to put them through other programs or not do a program at all, right? One of the major things that we address in these two chapters are looking at theoretical congruence when we're talking about adapting an intervention. Everyone talks about fidelity, 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 follow the rules, do exactly as it's told, which is great, but we need to have fidelity to the theory that's underlying intervention while being able to improve the fit of the intervention for the specific groups. So knowing what the working mechanisms are of the intervention and what are accessories that can be added to the intervention that doesn't compromise the fidelity. So this is concluding this part of the presentation. I have my email here. If anyone wants to reach out, I'm always excited to brainstorm and look at overlap and collaboration and how our projects work together and how can we branch out to new groups. I also think, I do want to acknowledge the funding for these studies that I worked on. This is my training grant, and then this is the parent grant for the studies that I taught, the efficacy, well as efficacy acceptability. I also like to, at the end of my presentation, say a little bit about me. So I am a corgi mom. This is my daughter Clementine, and this is my other daughter Puppy. She's a bearded dragon. And since moving to Las Vegas, I've become a big college basketball fan. Did anyone catch the game on Saturday? It was like a last-minute game winning. Oh, it was really good. So anyway, so I've become a big Aggie fan. So if you guys are at a basketball game, you'll probably see me there or try and find me. I have a lot of fun there. But I'll end there and let's have discussion and find some overlap. Questions?
You are. And then we'll back out to breathing and talk.
How did you choose the 100 women?
Oh, so the 100 women were, as they came into the treatment facility, they were screened for eligibility, and then the program coordinator reached out to see. So it was really just as they came. And then there were 11 cohorts. So once we had a group of around 8 women, we would start a cohort.
Right at the beginning, you said this is part of the third wave of cognitive behavioral therapy. Can you just like briefly say what are the others? I mean, that's the evidence that this is effective, likely to be effective, right? So and I don't know. I don't know that.
Sure. So when we look at the history of therapies, we started with behavioral therapies, and then we adopted cognitive behavioral therapies, which is very popular still right now, even though it's part of the second wave. So mindfulness-based intervention is not the only one in the third wave. There are others in the third wave. Acceptance commitment therapy is in the third wave. So it just adds an extra level. We went from behavioral to cognitive behavioral to now cognitive emotional behavioral to be adopting in more factors that are influencing therapy at large.
So the models would look a little different.
A little, yeah. So it's integrating more factors that we didn't use to consider.
Thank you for your presentation. I'm really familiar with John Campbell's work on research on how he's adapted the DSR for depression. And so I came to it because I wanted to see how it's adapted people with STD. I'm curious, how are you measuring sort of the long-term efficacy of people with a substance use disorder over time? Because I get the mindfulness part, and I got the curriculum and adapted that trauma and some of the other areas that and it's heavy on emotion, which is interesting because DSR is really about looking at thoughts and how to work with those thoughts instead of mostly in the emotional process. So and maybe that's sort of where the longer term piece that you said which would be coming in. How are you measuring, and I know you can talk about the control group, but how do you know that this is working for people with substance use disorders as an intervention?
Yeah, so the parent study is looking at the efficacy of the intervention, and they're right now at 8 months post-intervention. So the paper isn't out yet, but the immediate post-intervention paper is out, and they did find lower rates of relapse in the intervention group than the control group. And I can send the parent study if you leave me your email, and then I can pass that along. There's also a large body of literature by Wickiewicz and Bowen, which is that original slide that I had with all the mechanisms on it. They have a large group of mindfulness-based relapse prevention interventions that are also showing long-term efficacy in reducing relapse. So there's a lot of different ways that we can measure substance use. We can look at substance use days. We can look at different types of substances. There are different ways of measuring relapse, and then an individual with the alcohol use disorder may have a drink and not consider it a relapse. We may consider that a alcohol use day, and if they don't continue use, it may not be a relapse. So there are a lot of different ways. In our study, we had the timeline follow back intervention or assessment that looked at how many days they used substances to look at substance use days.
And was this same group also doing group therapy individuals?
So the only difference is that the control group had an active control during the same amount of sessions, same amount of time, same amount of weeks, but they were just learning about the neurobiology of vision. So and in our, we also assessed satisfaction in both groups to make sure we weren't just boring the neurobiology group, and they also had high satisfaction in that group. So that was the only thing that differed. The rest of the treatment, they all went through the same treatment in residential site.
And this is their first time doing treatment?
That varied a lot. So that is one thing that I wanted to look at that wasn't very well collected, and that we didn't have very good records of how many times they had been through treatment previously. And it's tricky how to measure that because we have individuals that check into treatment only the next day, but they've been in treatment, and we have individuals who have done 30-day treatments for every few months for the last 30 years. So it's a difficult variable to measure, but I do think that does influence it. We also have some individuals, our mean age was around 30, but we have individuals much younger that may not have been to therapy as many times, just by age, right? But thank you, and I'd love to talk more about it if you're in the mindfulness area.
So you talked in your introduction slides where you talked about some of the limitations of prior research. You talked a little bit about variability and acceptability. See anything in your data that gave you a little bit of information about, whether in this particular population acceptability is fairly tight or it's not outliers or anything.
Yeah, let me actually go back. I can't. This will be easier to speak to. We didn't have super large deviations when we were looking at our correlation. So if we're looking across here, satisfaction, formal, practice, informal, we don't have super big variation in acceptability. But what I meant when I was talking about variation in acceptability is more what is predicting. Do we have enough variation to see a relationship between acceptability and the other factors, which is more what I looked at in these regression models. And really, as I mentioned, trauma severity was a positive predictor for both of the practice predictors, and we didn't have any predictors of satisfaction. So that was, I really want to figure out, I've tried to run a few more exploratory analyses to figure out what is influencing satisfaction. One thing that I found so far was craving at baseline influences satisfaction at session 2 positively, or no, so negatively, more craving, less satisfaction. Which again, I do think there are a lot of third variable effects here, and I don't think it's necessarily a direct path. I think that craving may influence emotional distress, which influences satisfaction.
And you did pretty much like linear regression.
Yeah. Yes, and that's one of the limitations of having, although 100 in an intervention group is actually a pretty good size. I went through and did the psychometrics for the new scales as well for the satisfaction and practice scale. The practice scale was originally it's just a one scale, but was designed to have 2 factors, which it did. So I used the 2 factors separately. But it's difficult because typically when we do psychometrics and factor analyses, we have 500 cases. But in order to get 500 cases to go through a 6-week intervention, it would take too long. We just don't have enough funding to be able to do that large scale intervention. So we are slightly limited by the number of cases to be able to do more complex analyses.
I just want to mention that yesterday in class, we learned about the surface structure. It was interesting that we got that. So with that in mind, going forward with your research, are there any specific groups that you're thinking of adapting this kind of mindfulness? I mean, they can be adapted to any group geographically. Which ones would you want to further explore?
Sure. So I'm actually right at, I'm going to start next month on a 3-month post collection. I adopted an intervention last semester for an online interactive mindfulness intervention for first-time college students, first generation, first-time freshmen. And this was just kind of a pilot test to see if online interactive models would work. My goal is to use that as just preliminary data to get funding for a larger study where I can compare online interactive to in-person, kind of for that cost effectiveness piece. So I want to see it, because if we can deliver online interventions that are interactive, they have games and movies and kind of things to watch and to interact with. If we can make that effective, then we can disseminate that larger. And I think it's really great to introduce mindfulness at that first time going to college point, especially for first generation students. As a first generation student, it's a very complicated and busy time and very feeling lost. So I think integrating mindfulness as a coping mechanism, something they can take all the way through college. So that's an area that I'd like to go into. Integrating the substance use piece to it, because college is a popular time for binge drinking and for experimenting with new substances. So that's the goal long term. Thank you.
Sure.